So what I'll show you is the way that we do it here in Sports Groin Pain Center and the way that we have developed during the years. And there will be sort of a focus on the soft tissue, the adductor, the inguinal, and the iliopsoas for the relating it to our entities. And the other thing is, depending a bit on time and how much we can do, we could do how we do some of the hip examinations, and as we go along, any questions will be very welcome. Discussions, we'll take it at the end because otherwise we'll not make all of it. So let's start with this. I start with the psoas because I think this is one of the areas that is a little bit, some would say controversial, I would say just a little bit difficult, and that you need to learn. Strength of the psoas, if you do like this, if you lift your leg and I hold it here, then this is a psoas, but it's also the rectus femoris. It's also a question of how strong he is in his quadriceps to hold the knee, and it's also the tensor fasciae lata. So we're mixing a lot of things when we do it like this. So we try to isolate the iliopsoas as much as possible. So I take him up here in this position, about 80, 90 degrees up here. And then I say, pull your knee towards your nose as much as you can. And then I push, and you just hold. And hold, and good. I shouldn't, with my size and strength, I would say my experience is with a normal recreative footballer who is in no elite or anything, I should not be able to break him in this position. Some of you guys will be able to, I'm sure, but still, they are very, very strong in here in their psoas. So they should be. And my experience, as I just talked to one of you out there and told that sometimes I have big defense elite players lying there, and I go to the good side and I do this test, and they pull, and I can't break them, and they smile and say, yeah, this little guy, that's fine. And then I go to the other side and I say, okay, this is the side where you have problems, and if I have the feeling. So I start here, and you can very often you can feel it, that he's not that strong. And then I tell him to hold, and then you should see his face, and he looks very disappointed, because they are weak. It really matters. And as soon as they have a problem there with the psoas, they're very often weaker. And this is a very good illustration for a lot of players for motivation. You can see you're strong. This is your kicking leg, and you should be much stronger on that side. So it's very important that you're strong there. So this is the way we do this, and we ask both for strength and, of course, is it painful, uncomfortable when we do the test? It's another indication that it might be a psoas-related problem. I know when I do this, I, of course, am also stressing the hip joint, and I'm stressing other structures. But so the pain, you should be a bit careful. You should ask, where's the pain? Is it a pain that you know? And so on. And you should do your full examination. But then we do the palpation of the iliopsoas. And it's difficult with so many to show directly, but I'll try to show it here. I find the Cias here, the anterior iliac spine here. So, and then I put my fingers like this on each side of it. And yeah, so I put my fingers like this on the lateral side of the rectus abdominis, and then I just sort of put my fingers in and say, take a deep breath and relax. Give me as much room here as you can. I know it's uncomfortable, but try to relax. One more time. And when you do this, you can feel you get a centimeter more, like this. Okay, so now you lift this leg 5 centimeters. And now I can feel I'm rolling, and you can feel it as well. I'm rolling over your psoas here. I can feel the psoas like this, and you're rolling with your fingers like this, and you can push up and down on the skin. And if you go further up, you will get in trouble with a lot of other stuff. If you are at this level, you can feel it, and you can feel it all, and you can push all the way down to the ligament. So this is a good spot to touch and find the psoas, and do it on the good side first, and then compare, because it is uncomfortable, of course. And in some situations, especially if there's a bit of a belly, there wouldn't be with all the elite players, but some of us recreationals, there might be some more. And then it can be a bit more difficult to get in there. But you can, in most patients, get in there. So this is one side. The other one side is here. So I give you, I learned it's called a wedgie in English. A wedgie, when you pull up the pants like this, yeah. So I find the Sartorius. And how do you find the Sartorius? Well, you could put him in this, like a tailor is sitting. It's called the tailor muscle as well. So you hold your leg there, and there we see the muscle comes up very nicely. So I find the Sartorius here, put my fingers in the proximal end, just close to the inguinal ligament, and put the leg down again. Keep my fingers there. So now I know I'm on the medial side of the Sartorius. And then as close up to the inguinal ligament as possible. In this triangle, it's the only side where the psoas is located subcutaneously, where you can come directly to the psoas. Medial to the Sartorius, yeah, and then as proximal as possible. This combination. You could also say lateral to the femoral artery. So if you're in doubt, if it's jumping too much when I push, then you can go for the artery and make sure that you're not got too medial. Because if you're on the artery, you're also on the femoral nerve, and it's very uncomfortable to be compressed there. So you have to get out where you can feel the Sartorius. You're just going over the Sartorius, and then all the way up to the ligament. This is where it is. And you can confirm it when you have your fingers there, and you lift your leg, and you can feel easily the muscle is contracting under your fingers. If you're a bit too low, you won't find it. You have to go a little higher, and there it is. And this is where the psoas is. So, and then again, looking for pain there. So these are the two of the tests. And the last one, if you come to the end of the couch and stand at the end of the couch, I do the Thomas test. And usually I would do it like this. And then if you sit down on the edge of the couch, you take, for illustration, you'll take this knee, like this, and then I help the patient down, like this. And then I stand in here. I like to pull him to the edge of the couch, like this, so that his leg is free. And from here, holding him, the lordosis is as stretched as possible. Of course, I can push and get him up here, but I get a feeling if he's very tight or not. I can see he's got a tight rectus here. See, his rectus femoris is a bit tight. But then I would, in this position, hold him here, and then I would do stretching here. And I would ask, is this just hard, tough stretching, or is it painful? Very painful. So we have a patient. Good. Okay, and then I would make sure that I help him up again, because it is a bit of an uncomfortable position to be in if you lie up again, please. So, and we recently looked at our ultrasound results and compared them to these examinations, and we actually found that this test was very much in concordance with the ultrasound results. If it was painful during psoas, during the Thomas test stretching, it was in concordance with. We also found pathology with ultrasound of the psoas tendon, the distal part. So these are the 3 tests, 4 tests if you take 2 palpations, that we usually use for the psoas. Then for the adductors, it's there's a lot of squeeze tests out there on the market. You can do a squeeze up here. You can do a squeeze with a fist in between the knees. You can have a sphinctometer to measure pressure. You can do it in many ways. One of the more silly ways is the squeeze test up here in this position, because if you do a squeeze test up here, you are testing everything. I mean, think of all the stability you have to do. You can feel it. Your abdominals, your low back, if you have any problems in this region, you will get a result from it, and you would not actually know what you're testing. So you could do it as a test to see if there's pain, but what we usually do is to try to isolate the adductors as much as possible, because it's the adductors we're looking for. So we put them in this neutral position, first toe pointing straight up. When they are in pain and weak, and when they really have adductor-related problems, they really like to go out here and do the squeeze test, because then they can use other muscles. But we want them to use the adductors. So I put my hands in here, as you've seen a lot of times these 2 days, and you press, and you press, and you press, and And as much as you can. Good. And relax. And then I ask for pain. Is it the pain you know? Where did it? So someone says, yeah, it hurts back here, or it hurts up here. Then I would know it wouldn't be the adductors. We were just stressing something else, because I know, of course, we are stressing other things in these tests. But if he says, yes, it's right in there, then or right in here, because now I'm on this side, then I'll go up here, and then I'll find the adductor longus tendon. And the adductor longus tendon is easy to palpate. It's like the tendons. You can roll over it. It's very easy, and you can follow the tendon all the way. In the acute setting, there could be pain in the muscular-tendinous junction, or at the tendon. In the chronic settings, I think sometimes they have active trigger points in the muscles and increased tone, as Adam talked about. But to me, the main thing is the enthesis, where it goes into the bone. So I follow it all the way up to the bone and palpate it at the bone, where it enters or hits the bone, so to say, and then the square centimeter around there. This is where I usually find that the patients have pain when they have adductor-related problems. You can test for the gracilis, as Ernest Schütters talked about. If you roll over the psoas there, and you just slide down medially, inferior, posterior, you'll find the gracilis as a flat tendon there. So it's quite easy to palpate it. So you can follow the gracilis into the inferior pubic bone as well, and palpate there to see if there's any pain. So you palpate these two sides, and especially it's the adductor longus that I find that is painful. And if it's the same place as he had pain when he did the squeeze test, well, then to me, at least some of the groin pain is related to the adductor longus muscle. I would say now I have a squeeze test that generates the pain, maybe even he's weak there, and I have a palpation exactly the same place that generates pain. So to me, it's a good indication that this is adductor-related problems. And this is in the definition that we use as well. Then the inguinal. It's a bit more tricky. We don't have as much evidence on that, and you can see that from Phil's lecture yesterday, talking about the bulging of the posterior wall when we do ultrasound. We can't really be sure. You see that in a lot of normals. But you could do it the other way around. You could say, now I have clinical indications that this is an incipient hernia or inguinal-related problem. So I want an ultrasound to show me that the posterior wall is soft and bulging and something is happening. If it doesn't, then I will be in doubt and go back and examine again. Is it really a sports hernia problem, or what is it? I wouldn't start with the ultrasound and say, okay, we have a bulging, this is an incipient hernia. It's not. So you have to sort of go the other way around, because we have a lot of normals who are walking around with these changes. So what I do is I do a couple of tests. If you flex here, go like this. And I say make a sit-up as much as you can there, and I push, and you hold, and you hold, and relax. And in this simple test, do you feel any pain? Any pain you recognize? Where do you feel the pain? And if it points directly to the side that we are in suspicion of, then okay, this could be another indication of it. I could also do it like this. If you push this shoulder up in a sit-up to me, so you do an oblique, and you push like this, asking for the same, and then going to the other side and do it again. So you have a simple sit-up test, and this is reproducible if you do it in patients. We've tested that to see whether there's pain. And again, always ask, is it the pain that you know? Is it the same pain as we had before doing the test, etc., etc. You could probably combine it with an adduction at the same time and other combinations, but what I've tried to do during the years is to simplify it as much as possible, because otherwise you test a lot of different things at the same time, so you need to somehow try to sort out which is the most precise way to do it. Then what I do here is I go to the pubic bone and palpate, and I palpate at the rectus tendon, where it goes to the pubic bone. I palpate it here at the pubic superior edge of the pubic bone, and then follow it down on the front. I palpate in the symphysis joint to see if there's any pain. In my experience with the long-standing groin problems, there's not much rectus abdominis related pain. But as soon as I get a little bit more lateral, especially with these patients, I find that there's pain. And especially at the conjoint tendon insertion, that is the pubic tubercle. Sort of when you feel on the upper edge, you have this feeling that you're palpating here, you have the symphysis joint here, you're palpating, and then you get sort of to this corner. You feel like it's a bump or a corner there. And this is where the transverse abdominis and external oblique is going in. And this is where you will find when they have a soft posterior wall and weakness there and that they are painful. And we find in doing ultrasound in these patients that we can often see that they have a swelling in this area. So to me, it's the pain with sit-ups, it's pain at that tubercle, the history, of course, and the location of pain up here. And then I have the patient standing, and I don't think we should do this. Well, no, this one, yeah, now you know what I mean, yeah. So I'll palpate in the inguinal canal through the scrotum. So I do it with the patient standing and me sitting, and I spend some time doing it, so I'm really careful getting up there in the external opening. And what I often find is that they are sore in the opening, can be a little dilated. There could be a feeling of some more soft end point than in the other side, but it's very, very subjective. So I wouldn't say that this would be something we could reproduce. But the soreness, when you put your finger up there, and especially when you then, if the patient is standing in front of me here, then I put my finger inferior and lateral in that corner. This is where the posterior wall is, and this is where they often are clearly most sore. So in my mind, they're sore, and I put my finger there. They're pain at this at the pubic tubercle, and the history is confirming it. So to me, this is a clinical indication that this could also be an inguinal-related problem. And then what I would do would be get an ultrasound, asking for this by someone who I know can do it, because it's an ultrasound and an ultrasound and an ultrasound. Can be three very, very different things. So it's very important that you know what you're looking for, and both Nabil and Ahmed here is very good at this. They know about how to do it, so this is very good. Sorry? Yeah, it's for the hernia, yeah. Or sports hernia or incipient hernia, or as we prefer to call it, abdominal or inguinal-related groin pain, since it is not a hernia really. But there's a bulging, there's a soft spot there. And what we then do, our algorithm is to actually get the patient to do the rehab program, do the exercises, a lot of abdominal strengthening, and the abdominal strengthening should be in the extension, because whereas a footballer stretching his abdominals, it's not in here, it's out here. So it's very much in these situations. So when they're kicking and tackling and using their muscles in this position, so it's important that they're strong there, and especially also that they're strong eccentrically. So a lot of work on the Swiss ball with this is very good. Core stability is important as well, but to me, core stability is 10% of it. The rest of it is something else. You have to put a lot of more strength and coordination in it. Core stability is an important thing, but you don't get really strength from core stability. You get yeah, exactly. So what we now looked at is the psoas, the adductors, and the inguinal, the three entities. And the psoas, I would say, pain when stretching in Thomas test position and palpation pain. Then, in my mind, we are looking at the psoas. Pain with adduction against resistance and palpation pain at the same side, we're looking at adductors. Pain at the pubic tubercle, pain in the external opening, in the posterior wall, we're looking at inguinal-related, sports hernia-related stuff. But in all three cases, of course, it should fit with the history, fit with the complaints of the patients, etc., etc. And then you would always say, okay, but we have this X-ray showing us maybe some FAI. We have this suspicion, could it be a hip joint problem? So we have to examine for the hip joint as well. And I'll just show you a few things that I do until the next group is coming. So what we do, you could say a lot of the patients who have hip-related problems, hip joint problems, would have pain when you do a max flexion. Very often they have pain in this position. But if you have a psoas problem. If you have a very sore conjoint tendon or adductor, and you do this, it will give you some pain as well. So, but if this is not there, and I think this is very much the case with a lot of these diagnoses, is that you have to combine a pattern of things that are there or are not there. So you're excluding things by having negative examinations as well. So I would say in this position, I would find some pain. This usually generates no pain for the hip problems, but if you do an internal rotation, you'll find often that they have pain. Again, you're pulling the psoas in this position. Psoas is coming in here, so you're stretching the psoas here, and it's very uncomfortable if you have a psoas problem as well. Michael?
But how can you differentiate by the clinical test between a psoas problem and an intra-articular problem? We frequently use intra-articular injections before examination, but without that, for me it's just difficult because, as you said, in many hip problems, the psoas is also tight as a response to the intra-articular problem. Is there a way that you do it without injections? Because for the patient, they don't like to have an intra-articular injection.
I agree. Yeah, that's right. I agree. This is the point I was going to make now to say that I do these tests. I of course do the. I need to get it down a little bit. Down at surgeon height. That's me. So I put it. I do the impingement test. I usually, again, I'm not that big, so to me it's easier. I'm not very comfortable doing it like this, so I like to do it up here. So I do a deflection, adduction, and then I say, okay, this is an impingement test, and I do like we do with the Hawkins test. I squeeze all the way around here, and if he says there's no pain here, it's not not really. Then I think, okay, then it's probably the psoas that is generating pain, because I find that the FAI test is very rarely negative if you have an intra-articular problem. So that, in my mind, would be a test that would exclude, not totally, I know nothing is total 100%, but to me it would exclude that. Very often this is painful as well, I agree. So you have pain both on the psoas tests and you have pain doing this. So is it a psoas or is it a hip joint problem? There's two ways that you can go around that, I think. In my experience, the way I do it, and this is, I mean, a lot of this is not evidence-based. A lot of this would also be on experience, and then the examinations I showed you before are all tested and reliable. But now we're talking the differential stuff and then the new stuff, so it's a bit more experience-based. But I would say sometimes you have this feeling, this is a muscular problem. And sometimes you have this in your back of the head, this feels, well, he's sore at the psoas, but as soon as you do the impingement test, he's under the roof. It's really bad. So I tend to do that. So if I have the feeling that this is a hip joint problem, I'll do as you do. I'll do the injection, 8-10 cc's, ultrasound guided, into the hip joint. Make sure when you do ultrasound guided, you can see that it goes like this, so you know you're in the right place. You see the capsule is lifting off from the femoral neck, so you know you're in there. And then you reproduce your examinations. Sometimes it's not feasible to do it on the same day. You don't have time to see the patient again and stuff like that. So I instruct the patient, provoke your hip, make a couple of tests that you know really hurts, go in, get the injection, and the next couple of hours you do it every 15 minutes, and you make note of it, and then you send it to me on an email, or give it to me, or whatever, how you do it, and then you get the impression, did it work or didn't it work? The best way is, of course, to do it, have him take a walk for half an hour, and then take him in and do the same examinations again to see if it took away the pain that you found before. And if it takes away the pain, then I have a very high tendency of saying this is an intra-articular problem. Then you can always discuss whether you actually need to do an MRI of any kind, or you can go straight away and say this is an intra-articular problem, so now we will have to decide whether we believe that this is something that can be cured by rehabilitation, which we'll hear more about this afternoon in the session with Michael and Kay, where Kay will talk a little bit about if you can give exercise therapy for intra-articular problems. But this would be my sort of way of distinguishing between these. Yep.
Specific test for the referral pain.
Referred pain, yeah. I'm not a manual therapist, but I've learned from the manual therapists to do very simple tests. I do a couple of tests for the SI joints, and I do some springing, skin roll tests for the low back. And I do it on every patient I have. And I do it because it is a problem sometimes, and it can be referred pain, and you can get far out there, and then you realize this was actually something coming from the low back or from the SI joint that was locked. And sometimes when you've had hip problems or psoas problems, whatever, for a long time, you can get a dysfunctional SI joint, and of course, if you don't discover that, you can do all the hip arthroscopies and labral refixations and everything. The patient will still have some pain, and you have to realize where that comes from. So, and I guess a lot of you guys are much more used to do that. I can show the version that I do. I do the P4 test. I take the patient up in this position, and I do like this, asking for pain. I do the Patrick Faber test, Faber test, yeah, whatever you call it, like this. I do a springing on the SI joint from with the patient prone, and then I do Gillet tests, forward bending tests, dog tests, the tests where you're sitting behind the patient and he's standing up, lifting one leg, going up and down, or flexing, and there's a number of tests there. So, but again, this is not my specialty, but I think that in most cases doing these tests, I get the idea, oh, this is a problem, and then I involve someone who is an expert in this area to make sure that this is treated as well. Good. Comments? Questions? There's a number of other tests. I mean, the lock roll test, where you do it, where you're rolling here. I would say it's a good, if the patient is very painful when you do this, I would really think hip joint inflammation, synovitis, something is happening up here, because you're really having a relaxed leg here. You're not stressing very many muscles or anything else. So in this situation, I would be very, I would think a lot of the hip joint. You could also use it as to take a look at if there's a capsular laxity, and some use it for if there's a springing when you do like this, and it should sort of roll back. There should be a springing in the capsule, and if it's just flat falling out there, it would be either often it would be, especially if it's not bilateral, it would be that you had a trauma, subluxation trauma of some kind, or that you've been in the hands of a hip arthroscopist who did some capsulotomy to do the hip arthroscopy, and sometimes it can, in rare situations, result in a little bit more lax capsule and some sort of instability. Some call it microinstability, well, whatever. But it is a possibility. You could also do if you move to the side here, right to the edge. And you hold that. Good. So I take the leg out here, or you can do it at the end of the couch, take him down there. And then you could say, you could do an apprehension posterior impingement test. It's got a lot of names. What I usually do is I do it this way. Now I push the femoral head that way, posterior. So I stress the joint there. And then I do it the other way around. And I push the femoral head to the anterior capsule and stress it there. And this is very much, I mean, like in the shoulder, all of it is indirect tests. You can never, from shoulder tests, find the exact intra-articular diagnosis, but you can be quite sure that something is wrong in there and you have an indication of it. And this is the same, I think, with the hip joint. So if these tests are positive, then as Michael asked, when do I do it? Then this would, of course, be the more positive hip tests I have, and the more I can sort of rule out the muscles, the more I tend to go for the hip joint, and the more I go directly for the injection test or for the MRI. Yeah.
Having a problem. So that you can give how you test internal rotation? Do you test it soft or do you test it with a hard endpoint?
Yeah, you mean,
Because we did a study on that, and as we have seen yesterday, there's so much variation in internal rotation depending on the biceps
Yeah.
we investigate.
yeah. Yeah, both that and also on the capsular status and the muscles. One of the tests that I never really understood was this test, and then measuring from here and down there. I mean, it's rubber band in meters. It can be anything, and as a good physio can go in here on the rotators and work a little bit for 5 minutes, and then suddenly you have another distance here. So in a lot of these cases, so I don't have. I agree with you. It's very difficult to. Is it a soft endpoint? And what I usually do is as I learned from the physios, that they say, okay, this is the feeling, this is a range of motion, and then you do. I don't know what's the name, how you say it in English, but we say we do an overpress. So we press, and then we do a little more. So we do it like this. Does it stress something? Does it actually give an extra stress there?
Well, I think before we have any
Yep.
more questions, everyone else is waiting to come into this workshop. The other guys have all switched around, so it's a
Thank
good
you.
sign that there's so much interaction